So first, let me start with introductions. I'm Lisa Simpson. I'm the president and CEO of AcademyHealth, which is the Professional Society for Health Services Research and PHSSR, and we're delighted to be partners with the National Coordinating Center in helping to bring your findings, your work out to policymakers, as well as working with all of you to help you develop your methods and do even better, higher quality, more research. So we have three terrific speakers who are really going to give you the meat of what's going on in Washington these days. I'm going to briefly introduce all three of them. The format of this session is I'm going to give you a kind of frame-setting overview of the Washington update. And then we're going to actually have a Q&A conversation with our three panelists. I'm going to throw out some questions for them. And then we have a mic. Doris is over there and has a microphone, and she will circulate. And we really want this to be interactive and helpful. I work in Washington these days, so I sometimes forget, that it is a bubble. And what we think and work on is not always well known outside. So first, to my first right, far right of that group, is Jeff Levi, who would never be said to be on the right. Sorry, Jeff, who is the Executive Director of Trust for America's Health, where he leads the organization's advocacy efforts on behalf of a modernized public health system. Jeff is also, importantly, the chair of the National Advisory Group on Prevention, Health Promotion, and Integrative and Public Health. To his right is Paul Jarris, who is the Executive Director of the Association of State and Territorial Health Officers. And prior to his appointment, Paul served as state health official at the Vermont Department of Health. And throughout his career, Paul has maintained an active clinical family practice. And our third speaker is Bobby Pestronk, who is the Executive Director of the National Association of County and City Health Officials, where he represents our nation's local health departments and their staff, many of whom you work with or are from. Prior to his position at NACCHO, Bobby served as health officer in Genesee County, Michigan for 22 years. So we have really deep expertise here at the table. So with that, I'm going to now just give you some context-setting sort of points of information about what's going on in Washington. So first, as I thought about this talk, I was reminded of this quote. It was the best of times, it was the worst of times. It was the age of wisdom, it was the age of foolishness. And we all remember the first part of Dickens' start, but we often forget this next clause. And I think they both very much characterize what's going on in Washington and our country these days. So as we think about what are the examples of, errors. Let me get rid of this. All right. Okay, we'll start over. The best of times, the worst of times. And of course, this is from A Tale of Two Cities. So what are some examples of the best of times? Well, obviously the implementation of the Affordable Care Act, and Paul Keenert this morning in his luncheon presentation really covered this in more detail, but obviously improved coverage in terms of health insurance and the benefits. A very strong focus on prevention and population health, and also actual new money, demonstrations and incentives for care improvement. Now that's coming from the care side, but what we're going to talk about today, I think, is also what throughout the meeting is really about how these changes in the care delivery system is requiring us to rethink what the role of public health, particularly governmental public health organizations is. So those are some examples of the best of times. Now, what are some of the examples of the worst of times? Well, there are both direct and indirect threats, not only to public health services and systems, but also to PHSSR, what we're here about at this meeting. So what are some of these direct threats? Well, we've all heard way too much about sequestration and the deficit, but let me just remind you of a couple numbers of what that means. So in fiscal 13, the year we're in right now, NIH was cut $1.5 billion, the CDC was cut $300 million, the Prevention and Public Health Fund $58 million, and because agencies don't do reductions in force largely, a lot of that gets implemented through the extramural portfolio. So those of you who are extramurally funded researchers may feel even more of a brunt from this. And of course, fiscal 13 is just the beginning as we look to out years coming next. And so those are some of the direct threats, but in addition, we have other threats. For example, Congress's increasing desire to micromanage science. As Academy Health, we're very concerned about people saying that this kind of science is more important than that kind of science, or earmarking, or saying what is of more value versus other. So we've seen proposals from the House to increase the earmark for basic science as opposed to applied science. And then even more direct, if you've been following any of the commentary on this in the web, are the proposed bans on various types of social science. And in fact, the rhetoric around social sciences being soft sciences, and the Congress should be funding hard science, not social sciences, and bans on economics research, behavioral research, political science research. So those are also threats to the field of public health, PHSSR. So those are some of the direct threats that we're experiencing. But again, I want to not stay on the threats. Let's think about both the opportunities and the threats at the same time. So what does that mean for what we do in PHSSR, and what does Washington need from us? And our distinguished panelists here will tell us more about this. But right now, as we think about how we message on health services research writ large, including PHSSR, a lot of the dominant biomedical rhetoric is about cures. We're going to find a cure for cancer. We're going to find a cure for this disease. And we very much message around, well, we have to cure the system as well, whether that's the public health system or the medical care system, because it's ailing as well. And that some of the cures that we're looking for are how do we address or tackle healthcare costs, and how do we improve overall health outcomes. And already at this meeting, we've been talking about both of those. The other thing that we're learning from, that we've known, but it's really been reinforced in recent meetings with key policymakers in the legislature, in other governmental agencies, and information brokers and intermediaries, is that Washington policymakers really want information that helps them understand the impact of services and systems on outcomes. And while, in the classic Donabedian model of structure, process, outcomes, we need all three, and PHSSR is doing good work in all three, the Washington conversation is very much about the bottom line. What are the outcomes? Or at least that's when there is a conversation about research, that's what comes up. But again, being pragmatic about when that comes up. So with that, I am now going to go and join my colleagues sitting here and start with some questions, and then we'll get you all engaged as well.